Very good evening to all of you. At the outset, I am overawed by the mere presence of the best brains of the country. When I see that you are all here to get into the IITs, I'm told that you have to be one amongst 1,000. So you are the best brains in the country, and I am really privileged this evening to be speaking to you on a subject on which you may not be so familiar with, but I'm sure the School of Medical Science and Technology people will probably be a little aware. But considering the diverse nature of the audience, my job has been made a little simpler by my predecessor, Dr. Devdev. So the topic that I'm going to speak is a little different than what he has spoken, but the essence will remain the same, that it is a diagnostic laboratory. So what I'm going to speak is about Diagnostic Hematology Laboratory, the current workflow and the future perspective. As you know, when you walk into any hospital due to some sickness, or you are an attendant to a sick patient, you find that at the moment the patient reaches the hospital, some tests are ordered for. And one of the most common tests that are ordered for is a hematological test. That is complete blood count. By complete blood count, I mean that you will estimate the hemoglobin, the total white cells, the total platelets, and some of the red cell indices that you need to look at. So everything in the hospital environment is important for the diagnosis of the patient, the treatment of the patient, and the prognostication of the patient. So with that small introduction, I bring greetings from my hospital. That's the Tata Medical Center. Some of you must have seen it. If not seen it, then you are most welcome to visit anytime, whenever you go to Kolkata. This is a comprehensive cancer center, 435 beds. Comprehensive, by comprehensive I mean that all the areas of the human body which can get cancer are treated here by all the modalities of treatment, be it chemotherapy, be it radiation, be it surgical oncology. So I start with this picture that this is the bread and butter of a hematology laboratory. This is a fully automated blood cell counter. So this is the instrument, and this is an old instrument in our lab. We have a highly sophisticated state-of-the-art laboratory which strives to automate the equipments as and when they are introduced in the international market. So today we have 3 generations of automated blood cell counters in the laboratory. This is the oldest version of the machine. I will show you the next version. This is the Beckman Coulter DXH 800. This is the 2 counters integrated with a slide maker and stainer. Dr. Devdev has shown you the histopathology slides, and I am going to show you the hematology slides. So this machine, the moment blood is introduced into the machine through a tube which is called a vacutainer. You know what a vacutainer is? It's a tube which has a vacuum, and you collect the blood in that vacutainer or evacuated tube, and a defined quantity of blood is aspirated from your vein, and that goes into this machine to give the blood cell count. So this is DXH 800. This is DXH 900. This is the latest of the series, and this is yet to be installed in the laboratory but is on the floor. And this is incomplete because all that you are seeing here is 2 counters and 1 slide maker and stainer. And next to these will be added another unit called cellular vision. Cellular vision is nothing but digital hematology. So right now I'll show you what we are doing and what this machine is expected to do. That this machine, after a slide has been prepared, stained, will enter into the cellular vision platform, which is not yet in position, will be there in another month's time. It will do an automated differential blood count on that slide, which currently is being done manually by our fellows. Fellows are MBBS, MD in pathology, and who are being trained in hematology for 2 to 3 years to become hematologists. This is another machine which is just alongside that machine, which is not part of hematology, but this is fully automated clinical chemistry. Seamless, this has got track systems. You can find that the track is running here behind, and this is the track. So once you have the tube and put it inside the track, it will reach the right machine, it will enter into the centrifuge, and it will do everything that is being done manually at the moment. So many of the steps are automated. This is a part of the machine, and you can find that the things will get sorted out here. These are the various tracks, and the tube will go either to the clinical chemistry machine or to the hematology machine based on the barcode and the test that has been ordered for. I pay tribute to this man who is an electrical engineer. Many of you are here. Some of you are here electrical engineers. This man is called Wallace Coulter, an American electrical engineer, was working in the US Navy, and his job was to see that the paint that used to be made into the US warships last longer. So he was working with the paint that used to be painted, the hull used to be painted with, and while working on the quality of the paint, he found that the pigments that go into the paint making has to be estimated, counted, the number of paint particles. So he developed a particle counter, and that particle counter ultimately led to the first generation or the first man-made blood particle counter. So this is the publication, So this is the machine, the first machine that Wallace Coulter manufactured in his garage. There were two brothers, Wallace Coulter and Trevor Coulter. Both of them developed this small machine that could count particles. So automated blood cell counters are nothing but modified particle counters. So what is the principle? This man is Coulter. So the principle is called Coulter Principle, that as the red blood cells pass through this laminar flow in a single cell suspension, the moment it crosses the sensing zone, a signal is generated, and one signal is one cell. You just saw it. Similarly, if you have WBCs, it will count. You can see that there's an oscilloscope. You are very familiar with these gadgets in the labs, and this is nothing but the principle of automated blood cell counting. So the machines that I showed you work on the principle of three technologies and techniques. One is the estimation of volume, the estimation of conductivity, and the estimation of the scatter property of that cell. So based on that, which is measured by a laser that falls on that beam of fluid that goes in a single cell suspension on the machine, you find that different kinds of cells that are found in the blood will fall in different areas. You can find that This is one cluster, this is one, this is another, and this is another. And all are on the basis of the principle of VCS, volume conductivity scatter. So based on this volume conductivity and scatter, you can identify the cells based on the place where they fall on the scatter plot. This is a scatter plot. This is a scatter plot. And what all you can identify? You can identify monoblasts, myeloblasts, immature granulocytes, band polymorphs or neutrophils, lymphoblasts, everything that you desire to look at under the microscope on this slide can be picked up by these automated machines. So what it is going to do, if you have abnormalities, if you have abnormal cells, the machine is going to flag, give a flag. Flagging means abnormality. If there are monoblasts, which is not normally found in the peripheral blood, it is monoblastic leukemia. If myeloblasts are there, it is myeloblastic leukemia. If nucleated red blood cells are there, like here, that means there must be some hemolysis taking place in the blood. Because of that, the nucleated red blood cells are coming from the bone marrow into the peripheral circulation. And when you have platelets, which may be low, which may be high, which may be larger in size, you may have giant platelets. You have dengue coming in, where platelets will reduce. And some of the platelets may be larger in size. So everything can be detected in the automated blood cell counter. So this is the screenshot of one of the machines. You have the scatter plot to your right, and you have certain parameters on your left. As I mentioned, VCS, you have this is VCS, and this is neutrophil, lymphocyte, monocyte, eosinophils. So every cell has got a different volume, different conductivity pattern, and a different scatter pattern. Based on that, you can say that whether that monocyte population is normal or abnormal, that neutrophil population is normal or abnormal. So based on these numeric parameters, the machine will detect and tell you that there is polymorphonuclear leukocytosis, or it is called neutrophilia. Similarly, if you have lymphocytosis, you have eosinophilia, you have some allergic reaction in the body, you will have high eosinophils. You may have eosinophilic leukemias. So everything can be detected by the machine, may not be very precisely, but in a quite sensitive way. At least the machine will alert you that possibly there is something wrong in this blood that is being analyzed. Another screenshot, you can find that there are cells which are quite abnormal here. They're all blasts. So based on the presence of these abnormal VCS parameters, when you look at the peripheral smear under the microscope, these are the two promyelocytes, promyelocytic leukemia. Acute promyelocytic leukemia, which is a type of leukemia, and the patients become quite sick, and the machine, the moment you put the blood, is able to flag it that there are promyelocytes in the blood. Get alerted, look at the peripheral smear, confirm the diagnosis by looking at it and by many other ancillary techniques that are currently available. So I talk about a disease called Myelodysplastic syndrome. My medical colleagues will know what it is. My engineering colleagues will know now what it is. This is a type of blood disorder where in the marrow you have large number of cells, but these cells are so abnormal and atypical, they are not able to produce normal blood cells. They are too many in number, but your peripheral blood is showing very less number of cells because they are produced abnormally and they die inside the bone marrow medullary space and don't come into the peripheral circulation. Example, you just see here. This is the normal looking neutrophil, and this is the neutrophil that you find in myelodysplastic syndrome. So abnormal neutrophils. So this you have to see it manually. But when you have digital hematology, the digital hematology platform should be able to look at it digitally and say that this blood has got abnormal neutrophils. Possibly this patient has Milo dysplastic syndrome. This is the cell population data in myelodysplasia. You can find that there are different types of cells. The neutrophils can be dysplastic, the monocytes can be dysplastic, the blasts can appear, the platelets can be dysmorphic. So, large number of things can be there, and the machines will be able to give you an indication that there could be possibly myelodysplasia in this particular patient. So, when you look at this slide, you have a peripheral smear on the right, and you have two lymphocytes and one smudge cell here. The nucleus has got degenerated. These are the two lymphocytes, and you look at the scatter plot, everything is lymphocytes. 95% of the cells in the peripheral blood are nothing but lymphocytes. So, this is chronic lymphocytic leukemia in a 70-year-old individual. Peripheral blood is very classic, red cells are fairly normal, but what you find is only lymphocytes and lymphocytes. But your machine has been able to flag it as CLL. So, the machine is performing the same job as a human being would have done or would be doing, much faster and better way. So, similarly, as I mentioned, that you can find nucleated red blood cells in the peripheral blood, which is not usually normal, but when it comes, you know that RBCs are problematic. Probably the RBCs are getting destroyed. Because of that, the nucleated red cells are appearing in the peripheral blood. So, you have this histogram, which is the Wbc histogram. So, around here you find neutrophils, and the VCS parameters and the other things will flag it that there are NRBCs. So, this is the usual place where NRBCs will fall. Every day if you start looking at these scatter plots, hundreds of them, years after years, you will know what is falling where. So, it is very easy to identify abnormal populations. So, as I mentioned that it can detect abnormal cells. One of the most common medical problems in our country is malaria. You know, fever is very common, rural population is besieged with this disease. A lot of people die every year throughout the country due to malaria. So, when you have fever and you are collecting a blood sample for counts, if that sample can give, that count can give an indication that this is possibly malaria, you will be preempting malaria much earlier. It has been seen that if that machine, which is a new generation of machine, can detect malaria, here you find this red dots here are parasitized RBCs. You see this RBC, inside that there is a Plasmodium vivax parasite. So, the machine has identified few cells which are nothing but erythrocytes, but they are parasitized by vivax. So, wonderful gadget. So, fever, immediately do a count, parasites on the scatter plot. You do some confirmatory tests, it is positive, start treatment of malaria within 24 hours of the fever, rather than waiting for 7 days not knowing whether this is malaria or typhoid, and experiment with lot of antibiotics and lot of drugs, and some of the patients will recover, and unfortunately a number of them will possibly die. This is what I mentioned, that when you have that peripheral blood, that has to be examined by somebody. These are our fellows in laboratory hematology. They are MBBS, they have done their MD in pathology. Now they are doing fellowship programs in laboratory hematology, a 2 to 3 years program. And at the end of it, they will be qualified laboratory hematologists. So, this is the workflow in the hospital so far as routine hematology is concerned. This is the screenshot of the exact result that you get from the machine. You have right from the top, you have WBC, you have hemoglobin, platelet, RBC total count, you have percentage of different white cells, then you have absolute counts of the white cells, then you have certain red cell indices, and all these are important for interpretation in terms of disease diagnosis. And this is the rest of the portion of the report. And finally, when that fellow has examined the peripheral smear, he writes it here. Red cells are normocytic, normochromic, no abnormal cells seen, platelets are adequate on smear, no hemoparasites present. And he has authorized it, Dr. Gautam Gopal Bhagavat. Okay? So this is all that you find in a classical complete blood cell count. Then we come to something which is little different than blood. Sometimes we need to examine the bone marrow. And when you need to examine the bone marrow, you have to take out some aspirate from the bone marrow. And the usual site of bone marrow aspiration is the posterior superior iliac spine, which is behind. Either of the sides can be used. And what you get is a smear like this on the glass slide. And these are nothing but marrow particles, full of marrow cells or blood cells. This is a scanner view, so you are not finding cells inside. Next power will show you what are these cells. So you find all these are marrow cells. These will give rise to your mature RBCs, mature WBCs, neutrophils, basophils, monocytes, lymphocytes, and monocytes. So all these cells will produce that, and also platelets. This is a little clearer view. You can find that these are the precursors of white blood cells, myelocyte, metamyelocytes, okay, band forms. So all the types of cells are there. This is a band form. This is a little high power. You can see that they are larger, and you find that these are myelocytes. Okay. This is still a better view. You can find that large number of cells are there, and they are all cells inside the bone marrow. They normally do not come into the peripheral circulation. They produce mature cells which come into the peripheral blood. Now, you can identify this organism, object. What is it? Anybody? We'll get a straight away invitation to Calcutta. I will take him tomorrow in the vehicle in which we leave. He will visit the hospital and will come back in the same vehicle. Yes, fantastic. This is a MiG-29 frontline fighter aircraft from the Indian Air Force, just about to take off. Very good, good general knowledge. So you get the invitation, okay? Which branch are you from? Oh, good. So after this thing that I have showed you, which has got lot of manual interventions, though machines are counting, but still you have to confirm it under the microscope by those two young boys whom you saw. We move to something called digital hematology. Dr. Devdev introduced you to digital pathology, to digital histopathology. Now I will introduce you to digital hematology. I showed you the DXH 900. The digital pathology, the hematology platform is called CellaVision. This is a US FDA approved platform, European CE approved platform, which is for clinical use. And this platform in a month's time will be there at Tata Medical Center, and we will be using it for digital hematology. This is the workflow of the current hematology lab. You find that you collect a EDTA sample, you put it into the machine, the results are normal, it goes into the laboratory information system and the electronic medical records and gets signed out. But if you find that the result is abnormal in this blood, a slide gets prepared. You just found a automated slide maker. So based on the slide review criteria, automatically a slide will be prepared and will be stained, and will be ready for examination. In the current workflow, it is the human being who will be examining this slide. In the digital environment or the artificial intelligence environment, the machine is going to look at it. So, the technician or the laboratory hematologist will see it and will authorize it, whatever he sees in that smear. But when it happens in a digital environment, I will show you. So, what is the challenge here? The challenge is in the current workflow is slide review. So, if you can automate them, then your work will be simpler. So, what happens it? You have questions. What is the label of competency and proficiency one has? Can we gauge and measure that proficiency and competency of the individual who will be looking at it? What tools you use for staff training? Are the slides preserved? Is the abnormal cell location easily identified? Sometimes you identify an abnormal cell. Can you re-find it when you put the slide next on the microscope after 5 minutes? Have any abnormal cells been missed? Of course, you will miss it manually. How do you standardize the RBC grading? Sometimes you write hypochromia 1+, hypochromia 2+. That means the cells lack the quantity of hemoglobin that it should have. So, based on the quantity and the chromia of the cell, you either say it is 1+ or 2+. That is a little arbitrary, but if you digitize it, it will be more objective. Physical transportation of the slide to another location is difficult. You want somebody else to look at it, you have to take it from one place to the other. Which abnormal cell they want to show once the slide is transported? That again becomes a question. You have to either mark it or do something on the slide so that the other observer looks at the same cell what has been put as a pointer. So, all these are issues. And lastly, what if the pathologists want a second opinion? So, second opinion is always or sometimes required because it is a difficult diagnosis, a diagnostic dilemma. You are not sure whether it is leukemia of one type versus the leukemia of the other type. So, somebody else should look at and confirm that yes. What if the pathologist is not available in the lab, hospital or the city? Technology has so advanced that you can digitize the images and sell it on your cell phone for somebody to see. So, the challenges in hematology diagnostics necessitate the innovation and the change that is in the offing. So, you have pressure to do more with less, you have shortage of skilled manpower or personnel, demands to shorten the turnaround time, faster service to physicians, need for greater level of consistency and standardization, need for newer labels of connectivity and remote access. India is a vast country. The peripheral health centers in the rural areas needs to be connected to the subdivisions, from subdivision to district hospitals to tertiary care centers. Everything is possible by connectivity. And need for greater levels of traceability and quality control. You do not know whether the hemoglobin that you are estimating in my lab is the same as in the other lab, or the parameters that you have got from this lab is the same as in the other lab. So, there has to be a greater level of consistency. Okay, so for that you have this newer technologies that is available. I just mentioned about cell vision. It has got a hardware and software. The hardware is these. We are going to have this one. We are going to have this CellaVision DM1200. There is a higher version called 9600. It is only a higher throughput, but I think we found that this will be ideal for us. So, soon we will have this DM1200. So, this uses various types of softwares like CellaVision remote review software, CellaVision server software and CellaVision database. Okay, all these are required to analyze the cells. It has got millions of cells in the database to compare it with. I will come to that little later. These are the two machines. And this is the slide processing. These are the cassettes into which the slides will go. And this is the microscope that is going to scan the slide, the peripheral blood smear that I referred to. As of now, it is only peripheral blood in this platform, not bone marrow slides. That is more complex, but I think soon you will have platforms that can digitize the bone marrow slides and can offer service. So this is how the peripheral smear will look like. This is the pre-classification, pre-characterization stage. You can find, you will be better positioned to teach me that how this cell looks like. This is actually a neutrophil when it is being analyzed, and this is the actual cell. So review and verification, you can see that how many cells are there on the screen. You can see that all these are getting characterized and can be reviewed. And this is the principle of cell capturing. You have the digital camera, you have got the relay tubes, either it is 1.0 or 0.5, and you have 100x objective, 10x objective, and the LED table, which will all give you digitized images. So 10x objective into 1x relay will give you 10x magnification, monolayer of WBCs. 100x objective with 0.5 relay will give you 50x magnification. This is all mathematics. You all know much better than what I know of. So WBC analysis will depend on the WBC monolayer production and pre-locate items. So first you will locate the WBCs all around. That autofocusing will happen at 100x. Segmentation, feature extraction will happen at 100x. Then you will have the artificial neural networking to classify these different types of white blood cells. Then the images will be enhanced, they will be compressed and stored in the computer for future analysis. This is how it will be. These are the slides. You find that the WBC monolayer is there, and you will start scanning from here, and you will see that all these images will be captured. Due to paucity of time, I am little rushing through, but you will get the flavor of the whole gadget, that it has to produce a good quality smear, and every cell that it locates, the microscope locates, will be analyzed, and these coordinates will be recorded. So when you find an abnormal cell, you will always be able to find it because the coordinates will be recorded. So 100x images, you can find it like that, and it will scan it in a particular direction so that it is easier to locate, and this is how automatic focusing happens. You will find that ultimately this is a patented technology, and traditionally autofocusing requires 10 to 20 images to find optimal focus position. Cellavision utilizes artificial intelligence to predict direction and distance to the correct focus position given a single image. This requires 1 to 3 images. So this is a patented technology of Cellavision, which is a Swedish-based company which is present in Lund in Sweden, and now it is everywhere. Majority of the centers, major centers all over the world uses this technology. This is segmentation, 2 different cells, and when the cell is in focus, a segmentation is performed, and more than 350 features are calculated. So feature extraction is again important, features based on 6 main groups. One is form, then color, texture, detection in the form of vacuolations that you find in the lymphocytes as well as monocytes, Markov analysis, which is a probability function, and finally the wavelengths. All of you are more familiar with these terminologies than I am. Feature extraction, you know, pattern recognition, feature recognition is an important thing. And what is artificial neural networking? You know the definition much, much better than I know of. The human brain and the artificial neural network. Just for completion, I'll just read out what human brain does. It is composed of a large number of highly interconnected processing elements called neurons working together to solve specific problems. And what ANN means? It means a powerful data modeling tool that is able to capture and represent complex input-output relationships similar to the human brain. But I am sure sooner or later you will have artificial neural networks which are as good as human brain. We always say that human eye is the best camera in the world. But you have cameras much better than human eyes now, which can recognize with very high fidelity objects from far away distances, right from the cosmic radiations to objects to anything that is on the earth with a resolution of few millimeters or centimeters. So artificial neural networking has been able to identify these images. You see how complex has been the 360-degree features based on these 6 main groups that I have just described. So image processing, experts are sitting in the front row. They are highly technically qualified to process images. The images are normalized and enhanced after they have been pre-classified images and compressed after they have been they are usually in the JPEG. So this is one of the processed image. So artificial neural networking in the platform that I have just described, I will not go into the details, but this machine does wonderfully well in the current scenario, and I am sure when it comes to computing, the obsolescence of technology is extremely rapid. Today you buy a platform, today you buy a cell phone, it becomes obsolete in 1 month's time because some other version comes out and you feel that you have an older system. So technological satisfaction will never be with you when you come to something called computing. See the number of images it has analyzed, thousands and millions of images, which a human eye cannot do it in a defined period of time. You see, different forms of neutrophils. This is a ring neutrophil, dysplastic. These are all abnormal neutrophils. If you scan 100 neutrophils, you may find one. But when you digitize it, the whole slide gets digitized, you will find many of them. So WBC classic views, I will not go into detail, this is a screenshot. You have different and then you have to annotate them. So annotation is very important. When you find an abnormality, you annotate, it remains in the database of CellaVision. And that is how the database increases day by day. Look at these. Okay. So these are the classification view. Not only you can analyze WBCs, as I said, so more of them, you can analyze RBCs. Same in a monolayer form. You will find that you have WBC monolayer, which is little higher than the RBCs. How many minutes I have? 5. Okay, I will complete. So RBC monolayer will judge the shape, size of RBCs. I will show you that. This is the RBC analysis. Okay. How different quadrants are analyzed, measured. 35 or 36 images are grabbed. Images are grabbed in a 7:5 matrix or a 9:4 matrix, just like 16:9 or 4:3. And this is what it will give you, final output. So it will, based on the morphology, tell you whether the red cells are polychromatic, hypochromic, anisocytosis, microcytosis, macrocytosis. These are all the sizes of RBCs or the chromia of the RBCs. Okay. Then you have, based on the cell types, whether they are target cells, histocytes, helmet cells, and all these are pathologic or are of pathologic significance. If lot of spirocytes are there, then it becomes hereditary spirocytosis. Lot of teardrop cells are there, it can be myelofibrosis. Lot of acanthocytes are there, there is acanthocytosis. Okay. So all sickle cell disease, sickle cell anemia. You have parasites, just I showed you. You have malaria parasite, you have basophilic stippling, you have Pappenheimer bodies, Howell jelly bodies, they are all red cell inclusions, which will look like parasites. So everything can be discriminated in a very objective manner by digital hematology. It's not that you are doing it right now manually, but you will do it much better, in a more objective way, in a much simpler and faster manner. So this is a typical peripheral smear, and you get how do you annotate the slides, color, size, shape, and all that thing, and this will all go into the database of salivation. That is how the database gets multiplied. You see, this is again how this peripheral smear looks like, and you are identifying cells that are important for you. Okay. They are all inherited. This is how the annotation will happen. Target cells, spirocytes, helmet cells, like that you will annotate, and the diagnosis will be there, whether it is what type of anemia it is. Similarly, you have patients who suffer from dengue hemorrhagic fever. In the dengue season, platelet is very critical. You have platelet estimation, which is of critical importance. You are not sure whether the platelet count the counter has given is correct or not. You do manual counts. Some say it is 20, some say it is 10, and you are in a fix whether it is 10 or 20, because there will always be manual subjectivity. You want to remove this manual subjectivity by digital hematology. So platelet estimation view is this slide, and it will estimate. You can see that there are large number of platelets which are, you see, this is platelet, this is platelet. So many platelets are here. And then you have platelet anisocytosis. Platelets, when they are low in number, the bone marrow tries to make up for this loss. So bone marrow will produce platelets of differing sizes. So there will be platelet anisocytosis. Okay? So that the machine can pick up better than the human eye. So platelet analysis view, you see it has made into 9 quadrants, and you can have platelets classified into different size range, and you can know that the actual platelet count will be what. This I have already shown you. Body fluids. After the hematology, in the clinical pathology field, you do body fluid analysis. Whether you have cerebrospinal fluid, whether you have pericardial fluid, pleural fluid, or ascitic fluid, every fluid has got cells. So you can do by a cytospin. This is a cytospin smear. You see the round. This cytospin, the machine will make a circular smear and put it onto the slide, and then it can be digitally analyzed like hematology smears. I will not go into the details of that. This is how the images will look like in body fluid analysis. Okay, regions of interest you can know. And not only, I mentioned that presently this digital hematology is restricted to peripheral blood. Gradually it is moving into bone marrow biopsies, and soon you will have softwares that can analyze bone marrow biopsies, bone marrow aspirate smears. Time is not far away, and there are various advantages of these salivation. You can have expert review hubs. You know, trained human resource is very, very important. You have, you have currently the Ayushman Bharat program. The government is trying to network all the smaller areas with bigger centers, and that is only possible by networking. You know that there is Digital India initiative. The government is trying to integrate all the centers. So you will have remote reviews, you will have centralized reviews. Everything is possible provided you are living in a networked environment. Slide scan applications. Dr. Devdev has already handled it very elaborately. This is same to hematology. You can have bone marrow biopsy slides reviewed, and these are the 3 hematology analyzers in the digital platform which is currently available. You have DM9600, you have DM1200, which we are going to have, and a very small DC1 platform, which is just the beginning of digital hematology as when it started. I have finished my presentation. This is a slide which is, anybody can, this is 2019 we celebrated 20th year of Kargil war. So this is Kargil. After the Indian soldiers won the war, they are celebrating. And on the backdrop you have the Kargil mountains. So you are safe. So looking into the future, what I have presented to you, some of them have already become realities, and you will find that as time goes by, more of automation, artificial intelligence, machine learning, deep learning, and whatnot. And I think you are the people who will drive it. And I'm sure I have just given you a brief overview of what it is. I have not gone into the details of it, but I'm sure you have got some points as to what you should work on. Okay? Thank you very much for a patient hearing. At the end, I will fail in my duty if I don't thank Dr. Gorachan and Dr. Devdut for their tireless efforts to make this lecture possible, and my junior colleague, Dr. Paramita, who has also worked extremely hard to put up this program in place. Thank you very much.